Peptic ulcer disease or PUD. Peptic ulcer disease are the most commonly located in the stomach and duodenum. This is stomach and this is the part of duodenum. So, peptic ulcer disease commonly occurs in the stomach and the duodenum, and it also occurs in the lower part of the esophagus, jejunum, or rarely in the ileum, and it can be acute or chronic. Both can causes penetration of the muscularis mucosa. That means stomach has three layers: mucosa, submucosa, and muscularis. So ulcer in the stomach and duodenum both can penetrate mucosal layer of the stomachs and duodenum. So gastric ulcer is commonly occurs in the laser curvature of the stomach. 90% cases occurs in the laser curvature of the stomach. But chronic duodenal ulcer occurs first part of the duodenum. Here is the first part of the duodenum, and duodenal ulcers commonly occurs in the first part of the duodenum. Pathophysiology. The main culprit is Helicobacter pylori bacteria, which is a gram-negative bacteria. Gram-negative bacteria, and its shape is spiral shape, just like that, and it has multiple flagella. Because of this flagella, this bacteria is motile. Now, pathophysiology of the PUD. First one is h.pylori. Second reason, NSAIDs, and smoking also causes PUD. How h.pylori causes PUD? Now, h.pylori bacteria has different types of factors that are responsible for PUD, such as urease enzyme, CAG gene, VAC-A gene. That means CAG gene means cytotoxin associated gene. On the other hand, VAC-A means vacuolating cytotoxin A enzymes, and these three things can cause PUD. What about the urease? Urease is an enzyme that breaks down the urea to ammonia and carbon dioxide. Ammonia creates a neutral pH around the bacterium that leads to h.pylori exclusively colonize into the gastric type of the epithelium. We know that in stomach the medium is acidic, but increased amount of ammonia causes a neutral environment for colonization of the h.pylori bacteria. On the other hand, CAG-A1 gene, that means cytotoxin associated gene, enters into the cells and interacting with the numerous cell signaling pathways involved cell replication and apoptosis. On the other hand, VACA1 gene, that means vacuolating cytotoxin enzyme, this causes perforation of the cell membrane, and these perforations of the cell membrane leads to permeability or increase the permeability of the cell efflux of the micronutrient that is essential for the bacterial growth and bacterial life cycle. Two other factors which causes PUD, that is NSAIDs and smoking. What about them and how they cause PUD? NSAIDs like aspirin or any others drugs that are responsible for the peptic ulcer disease, and it's almost 10% cause. Smoking also increase the risk of gastric ulcer. NSAIDs and smoking impair the mucosal defense. When the mucosal defense is compromised, H. pylori bacteria can easily enters into the submucous layer of the gastric mucosa, and when they enters into the mucous layer, they can multiply and they can colonizing here and causes PUD. What about the clinical features? Clinical features of PUD. Commonly, peptic ulcer disease is a chronic condition and spontaneous relapse and remission lasting for decades. That means it's not an acute condition, it's a chronic condition and it can spontaneously relapse. It occurs again and again and it lasting for decades. That's why treatment of the PUD is necessary for long-term therapy. Long-term therapy for PUD treatment. And most of the patient is suffering with abdominal pain, which normally occurring in the epigastric region. And the nature of this pain is slight pain, not severe, slight pain in the epigastric region. And patient also complains anorexia, nausea or vomiting, early satiety after meal, and sometimes patient also complains anemia, hematemesis. These are the common clinical features of the PUD. Abdominal pain, which occurs normally in the epigastric region and it is slight pain, anorexia, nausea, anemia, hematemesis. These are the common clinical features of a patient of a peptic ulcer disease. Now the next question is, what will be the investigation for PUD? First and foremost investigation is endoscopy. We must do endoscopy, but here we have to notice that the bowel is clear or not. If the gastric emptying is not clear, then we have to clear the gastric content by nasogastric tube. Nasogastric tube helps to clear the content of stomach. After emptying the stomach by nasogastric tube, then we will do endoscopy, and it is the important investigation for PID. And we also diagnosis for H. pylori infection. For H. pylori infection, we can go for non-invasive and invasive method for diagnosis. In case of the non-invasives, there are serological test, 13 carbon urea breath test, fecal antigen test. And in case of the invasive test, we do histology, rapid urease test, and microbiological culture sensitivity. And these are the tests for diagnosis of Helicobacter pylori infection. In case of the non-invasive test, we go for serology, 13 carbon urea breath test, and fecal antigen test. In case of the invasive test, we go for histology, rapid urease test, and microbiological culture sensitivity. And here is the microbiological culture and sensitivity is the gold standard. Why it is gold standard? Because when we do for microbiological culture and sensitivity, we also identify the specific bacteria, and we can do antibiotic sensitivity test, and it also important for the eradication of the H. pylori bacteria. But when we go for the H. pylori eradication therapy, there is some common side effects. We will face some common side effects like diarrhea, vomiting, nausea, headache, rash, but it's rare. So H. pylori eradication can cause some side effects. They are diarrhea, vomiting, nausea, headache and rash. Indication for H. pylori testing. When we go for H. pylori testing, we already know that there are some methods for the diagnosis of the H. pylori infection, but when we go for H. pylori testing, there is some definitive indication and not indicated. We go for H. pylori testing and when we don't. If there is active PUD, then we go for H. pylori testing. If there is dyspepsia, if patient complain dyspepsia, then we go for H. pylori testing. If the patient is use long term NSAIDs or aspirin, if there is vitamin B12 deficiency, if there is idiopathic thrombocytopenic purpura, and these are the indication for H. pylori testing. But when we don't go for H. pylori testing, if there is gastroesophageal reflux disease or patient is asymptomatic, then it's not indication for the H. pylori testing. Then we go for surgery. What are the indications of the surgery in case of the PID patient? We go for surgery emergency case like perforation, hemorrhage. That means if there is the history of perforation or hemorrhage, we go for emergency surgery. And elective surgery when there is gastric outlet obstruction, persistence ulceration, recurrent ulcer. If there is gastric outlet obstruction, persistent ulceration or recurrent ulceration, then we go for elective surgery to reduce the peptic ulcer disease. Management. What will be the management of the PID? The first and foremost important management is H. pylori eradication, because we already know that H. pylori is the main culprit of PID. So first of all, H. pylori eradication is the most important management. So all patient with PID normally affected by the H. pylori bacteria, and H. pylori eradication, there is some indications: use of long term PPI along with 2 different antibiotic. So proton pump inhibitor along with 2 different antibiotics. It can be amoxicillin or clarithromycin or metronidazole. You can choose 2 of them, any 2 of them, amoxicillin or clarithromycin, clarithromycin or metronidazole or amoxicillin. Any two of them along with PPI you can treat for H. pylori eradication, and treatment duration should be at least 7 days. That means antibiotic for 7 days along with PPI, and PPI will continue after 7 days, and this treatment is extending to 10 to 14 days twice daily dose of PPI. And this high dose of twice daily PPI therapy increase the efficacy of this treatment, and this is very important for H. pylori eradication. And we also follow up the patient, and we also suggest them cigarette smoking, any types of aspirin or NSAIDs should be avoided. If there is needed for surgical treatment, we go for surgical treatment, but it's rare. Now, what are the complications? What are the complications of PUD? There are some complications of PUD patient: perforation, hemorrhage, and gastric outlet obstruction. What is perforation? Normally, when the contents of the stomach escapes into the peritoneal cavity, if the stomach contents leaks from the stomach to the peritoneal cavity, it causes peritonitis, and peritonitis causes sudden severe pain. That's indicate peritonitis, and it is the clinical features of the perforation. And here upper abdominal pain normally generalized, and sometimes shoulder tip pain causes because of the irritation of the diaphragm. Peritonitis leads sudden and severe pain, and sometimes patient develops upper abdominal generalized pain, and sometimes pain radiates into the tip of the shoulder because of inflammation of or irritation of diaphragm. And how we will diagnose perforation? Normally, erect chest X-ray. Erect chest X-ray is the indication for perforation. That means we can diagnose perforation of the stomach by erect chest X-ray. But what will be the findings in X-ray? There will be some free air. Under the dome of the diaphragm. Suppose it's the dome of the diaphragm. This is right dome and left dome. There is the accumulation of the free air because of the perforation, and there will be some free air accumulation just beneath the diaphragm, and it's confirm the perforation. There are some other complications like gastric outlet obstruction. Most of the patient complains nausea, vomiting, and abdominal distension. When we physically examine the abdomen, we will see there is a wasting, and patient will suffering from dehydration, and this dehydration will be corrected by isotonic saline, and it should be 4 liter. That means we correct the dehydration by 4 liter isotonic saline. And in case of the gastric outlet obstruction, we will do endoscopy. But before doing endoscopy, we must have to empty the stomach by nasogastric tube. But before doing endoscopy, we have to empty the stomach by nasogastric tube. And sometimes there is a hemorrhage, and this hemorrhage can lead to anemia. If there is a severe anemia, we will go for blood transfusion to correct the anemia.